I would like to pass the floor to Dr. Valentina Gogulancea of Ulster University on using geospatial and clinical data in machine learning models to estimate the risk of developing lung cancer in multi-country retrospective study. Okay, the floor is yours, Valentina.
Well, thank you very much. Thank you for the introduction and the invitation. So as Sandra said, my talk is about combining geospatial and clinical data in machine learning to estimate the risk of developing lung cancer. I will start with an introduction about myself. I am primarily a chemical engineer. I have a background in organic chemistry and have a PhD in chemical reaction engineering from University Polytechnica of Bucharest. And my PhD was primarily to do with modeling the chemical reactions that take place during the non-thermal plasma depollution of exhausts. So flue gases containing sulfur dioxide and nitrogen oxides. After a short period as a lecturer in Romania, I moved to do a postdoctoral research in Newcastle University in a multidisciplinary EPSRC funded project that looked at the wastewater treatment, and I was basically modeling bacterial interaction on a scale of 1 to maybe 100 microns. And after that, I moved further on to Ulster University, where for another postdoctoral position, where I looked at modeling different bioenergy production systems, and that was mainly to do with gasification. That was in 2020, and then in 2023, I switched careers a little bit, still at Ulster University, still a postdoctoral researcher, but more in the data science universe, and I joined the Lucia project. The Lucia project looks at better understanding the lung cancer risks, and it is a Horizon 2020 funded project that has over 20 partners, and our Ulster University team is formed of my colleague Aileen Lonnie, who did a lot of the work regarding the geospatial data collection and the literature review required for the environmental lung cancer risk factors. Dr. Debbie Rankin, who is my boss and the principal investigator on the Lucia project, and Professors Michaela Black, Adrian Moore, and Jonathan Wallace, who are co-investigators on this project. And I will talk more about the Lucia project and why lung cancer research is an extremely important area of research. So, the Lucia project. Why lung cancer? It is the most common cancer. It has the highest incidence rate worldwide, and it also has the highest mortality rate. This is mainly due to the difficulty in early detection of lung cancer, because the symptoms are very difficult to identify. It is also associated with smoking, and as such, there is a smoking disease stigma around it. And more importantly, the rates in never smokers for lung cancer and mortality and its mortality are steadily increasing. Just to look a little bit of what's happening both for both genders, I've taken here a graph from the Global Cancer Observatory that shows the lung cancer rates in Spain UK in Northern Ireland and Ireland, so basically on the island of Ireland, between 1994 and 2016. And you can see in this full line, you have the rates in the incidence age standardized rates in males in Spain, and then Ireland and Northern Ireland. And you can see a small decrease in these rates, most likely associated with the decrease in smoking rates among males. And then you have this very large increase in the incidence rates in females. And nobody is entirely sure because why this is happening. But you can see that they're also very close to becoming an equally male and female, that lung cancer is becoming almost as prevalent in males as in females, which is a big change. So the Lucia project, which is an acronym for lung cancer-related risk factors and their impact assessment, is looking at understanding the cellular pathways for lung cancer in both males and females. And it has, to do so, it has two arms. One is the prospective study, which is presented on this slide, where partners from 4 European sites in Latvia, Andalusia, the Basque Country, and Belgium are performing general population screening for both smokers and non-smokers, and using Lucia proprietary devices such as a breath analyzer or a spectrometry card. And after this initial screening, the high-risk patients are then moved on to the second phase of the project, which is the precision screening, which also involves a low-dose computer tomography. And then further on, the patients from this second phase are moved on to the third phase, which is the diagnostic, using a series of multi-omics pathology and the results from the Lucia proprietary technologies like SPOC and WBSP, which is a sort of patch that's attached to the patient. Using AI data analytics, we basically propose an alternative to lung cancer screening, which will enable earlier detection at an early stage and in a less invasive manner. The second arm of the Lucia project is the retrospective study, and this is the research that I will talk about today. So the retrospective study involves around 20,000 lung cancer patients and 200,000 control patients from 3 regions: the autonomous Spanish regions of Andalusia and the Basque Country, and the Liège province in Belgium. And in this retrospective study, we aim to combine the electronic health records of this cohort with the environmental exposure that they are that is associated to them, and their genomic data, and then develop novel lung cancer risk factors, or gain a better understanding of the cellular pathways that involve these. And our role in Ulster University and the research that I will talk about today is mainly concerned with incorporating the environmental exposure into risk models to predict the risk of developing lung cancer. And to do so, we have decided to use GeoAI approaches. GeoAI models, as you probably know, and the widest definition of them is that they are AI models that are working with spatial data or AI models that output spatial predictions. And to begin our work, we looked at the literature concerning GeoAI and the GeoAI applications in health. And we could identify basically 4 types of GeoAI techniques that are mainly used. And the first one that I will talk about is the AI models that use geospatial features. And they have been mainly developed for socio-environmental predictions. So a lot of random forests are used for the prediction of PM 2.5, particulate matter with a diameter under 2.5 microns, for the concentrations and the variations of the concentrations of particulate matter, or for socioeconomic status. And these are usually the easiest GeoAI and the most common GeoAI techniques that are in use. The second type are AI models that use the outputs of geospatial analysis, and these are mainly used for aspatial predictions. So if a person resides in a hot spot or a cold spot of air pollution or something related, you can then predict the risk of developing lung cancer, for example, or any other illnesses. There are also geospatial analysis that use the outputs of AI models, and these are mainly used for epidemiological studies, where the models are looking at the geospatial analysis is looking at the differences between the outputs of the AI models and the actual reality on the ground. And finally, and this is what we call true GeoAI, are AI algorithms that are tailored especially for geospatial predictions. And we haven't actually used this in our research yet, but it is planned for the next couple of months. And these GeoAI algorithms are actually addressing the spatial autocorrelation and the heterogeneity issues that are associated with geospatial data and that cause issues with conventional algorithms. Because, for example, the random forest models used to predict PM 2.5 concentrations are usually hit and miss. So some of them can work really well and some of them can produce results that are not as good. So I will, in my presentation today, I will only touch upon the first 3 types of models and the results we've had with applying them. The second step after looking at the GeoAI approaches was to look at the risk factors for lung cancer. And for this, my colleague Aileen performed an exhaustive literature review, and she looked at almost 200 papers. And we can see here that the air pollution is the one area that is mostly researched in association with lung cancer. We also have soil pollution, industrial emissions. We have radon, which is actually a well-known risk factors, and about 15% of lung cancer cases can be attributed to radon exposure. And we also have deprivation, urbanization, and access to green space. We also looked at papers that report risk factors for respiratory diseases and other cancers, because there might be some other associated risk factors in there that have not been flagged for lung cancer. So for each of these areas of interest, we looked at the geospatial variables that are available for both Spanish and Belgian, both the Spanish and the Belgian data set. And we also wanted to see how we can attach these variables, these exposures to each person. So we also have to look at the administrative details of each region. So for administrative details, so the spatial extent of we looked at the spatial extent of the municipality and statistical sectors, and also the postcodes. For air pollution, we used the concentrations of nitrogen oxides particulate matter, both with the diameter under 2.5 and under 10 microns, and ground level ozone. And as a source for these data, we used interpolated air pollution maps for the European Environmental Agency. We also looked at soil pollution, soil metal pollution, and this was again from the European Environmental Agency. Green space access for this, we used two variables. We used the normalized difference vegetation index that my colleague Aileen derived from satellite data, and the green space land cover percentage from the Korean Land Cover Service. We also looked at pesticide use, and because there is no database at the European level for this, we looked as crop cultivation percent or agricultural land coverage as a proxy variable. For radon, again, the Spanish and the Belgian national nuclear agencies hold information about the radon concentrations, and they classify areas according to their radon exposure zones. We looked at deprivation measures as an index or a quantile. For urbanization, we looked at the degree of urbanization, the population density, and the urban space coverage. And for industrial pollution, we looked for the European Pollutant Transfer Register. And we looked at the distance to the industrial facilities to pollute IARC polluting facilities, so facilities that whose emissions are classified as cancerinogen by the Institute for Cancer Research, or large combustion plants. And we also looked at elevation, as this was highlighted in one of the papers as one important risk factor. And then we went on to append this data set, this basically environmental database that we created, to the retrospective cohorts that we had. And as you can see in this table, we had 3 cohorts in varying sizes. And we also had different address levels for each participant. So for the Belgian data set, we had the full address. For the Basque Country data set, we had only the postcodes. And for the Andalusian Health Service data set, we only had the census tract, a mixture of the census tract or the street address. You can see also we had some missing address information, and the geospatial spread of the data set varied from between the cohorts. So we decided to append the information at the lowest possible administrative level, and that was the census tract. So my colleague Aileen, again, she averaged all the information from all the data sets presented before to the census tract level. But she also created a postcode data set and also a municipality data set, just to be able to check how the different levels will affect our analysis. And finally, we performed a systematic literature review to see what has been done in this area. So we searched for the terms geospatial analysis and lung cancer, and we arrived at about 16 entries. Most of the analysis was geospatial in nature, like fully geospatial. There were a mix of geospatial and statistical analysis, but there were only 2 studies that used a mixture of geospatial and ML techniques. And again, most of the studies used cancer registries and not cohorts, as we are doing in this analysis. So finally, we begin with the machine learning using geospatial features, where basically we have to followed these steps in our analysis. So we started with problem formulation, and we decided to use classification as a machine learning technique, which basically, so we can predict if a person will develop or not lung cancer. Then we perform data cleaning and harmonization that I will not discuss here, exploratory data analysis that I will, and then feature selection, model selection, model training, evaluation, and optimization, and then we could draw some conclusions on our results. So, as I was saying, we decided to use classification as a strategy, and we employed 12 machine learning algorithms. We use logistic regression, naive Bayes classification, support vector machines, both linear polynomial and RBF kernels, stochastic gradient descent, decision trees, and then we used also ensemble models such as random forest, AdaBoost, gradient boosting, and XGBoost, so extreme gradient boosting. We also used an artificial neural network, a very simple one, the multi-layer perceptron. And to do so, we took the demographic information from each data set, so that involved the age, the gender, the smoking and alcohol consumption of the patient, their clinical information, so comorbidities such as COPD or diabetes or a history of heart attack. And then to all that, we appended the geospatial information. However, as you know, we then performed exploratory data analysis, and we started with the correlation analysis for the geospatial variables. This is just a snippet of it, but you can see here in this corner that all the variables that we use as proxy for air pollution exposure were indeed highly correlated. Similarly, because of this is the results of the analysis for Belgium, but there are similar results in Spain. We could also see that because of the geography of Liège, most of the urban areas were at lower elevation. So the elevation here was negatively correlated with the air pollution exposure. What we didn't fully expect was that the soil pollution was also correlated relatively highly with air pollution. And then something that we more or less expected was that the access to green space, as depicted by the NDVI, the Normalized Difference Vegetation Index, is negatively correlated with particulate matter and nitrogen oxides exposure. Similarly, the correlation analysis between categorical and numerical geospatial variables showed us that the degree of urbanization, this degree of urbanization 1.0 means that the patients are living in an urban area, are negatively correlated with the radon exposure. And again, this is something to do with the geology and the geography of Belgium. But the issue here was that because of these highly correlated variables, we had to decide which of them we would include in our models and which we would leave out. So again, we had to perform we performed actually different feature selection techniques to decide and establish which of these geospatial variables we're actually going to use in our models. We firstly used the univariate geospatial feature selection. So from all these variables, we decided to use particulate matter, the concentration. We didn't. The soil concentration of nickel, antimony, and copper, the NDVI, as a proxy for green space access, the agricultural land cover as a proxy for pesticide exposure, the radon class as opposed to the radon measurements, the privation index, the urban space coverage as a measure for urbanization, and then exposure to large combustion plants and elevation. We also performed a second feature selection, which was model specific, and in this case, we used all possible combinations of these variables, and then we trained our model or machine learning classifiers, and then we decided, and then we kind of averaged we looked at what the best performances were given by all of these data sets, and then we decided to use these other features, which were particulate matter. The main differences between these and the univariate feature selections rest in the selection of heavy metals for the soil concentration, and then population density instead of urban space coverage as a proxy for urbanization. And then you may ask why, how did we measure the model performances and how did we compare? We compared them. And basically the most used model performance measure is the accuracy, which is the number of correct predictions over the number of total predictions. And in most cases, this works very well, but in our case, we have a very imbalanced data set. So only 10% of our cohort is actually going to develop lung cancer. So that means if we predict that everybody will not get lung cancer, the accuracy of our model would be around 90%. So instead of using the accuracy, we use the balanced accuracy, which is the arithmetic mean of basically the correct predictions in each class. So how many of the true positives are actually so the people who will actually develop lung cancer, divided by the true positives plus the false positives. So the people that our model predicts will develop lung cancer, but in fact do not. And the true negatives, the people who do not develop lung cancer, divided by the true negatives plus the false negatives. So the people that our model predicts will not develop lung cancer, but in fact we will. We also used the F1 score as a measure, which is the harmonic mean between the recall and the precision. And finally, we use which is again one of the measures that are recommended for imbalanced learning when one class is highly outnumbered by the other. And then we use the area under the receiver operating curve, which is a measure of discrimination ability of the model. And basically, the receiver operating curve is if you plot the false positive rates against the true positive rates, you will have a sort of this graph here. For a random classifier, this will be the plot will basically be the diagonal. For a perfect classifier, which is the aim, you'll have a point, and the area under this receiver operating characteristic curve will be 1. So we want a score that is higher than 0.5, which is basically the random classifier, and it's the equivalent of just tossing a coin, and under 1. Usually, receive a rock AUC score between 0.7 and 0.8 is considered good, and anything between 0.8 and 1 is actually considered a quite performant classifier. We could have used the area under the precision recall curve, which is basically plotting the precision and the recall and then drawing the the graph, but the raw KUC is actually better in the case for this. So by using the geospatial features after the univariate feature selection performed and combining them with the clinical data set, we obtained these results. We can see that for each of the classifiers that I have mentioned above. You can see the balanced accuracy for most of the classifiers is quite good, slightly under 0.8, but not by much. The raw KUC again is very good, around 0.85. And this brings me to the performance measure that is actually in most studies concerning lung cancer that it's most underreported because the results are quite bad, the F1 score. So this is an indication that our model does actually have a lot of false negatives or false positives. But this is, again, always the case with lung cancer risk models. So we also wanted to see how this can be used for screening and how many cases we would be able to find from the total number of cases. So this is performed on a training set from the Liège cohort. So if we would use as a screening method only if the smoking status and the age. So if we were only to call ever smokers and people over 50, we would have to screen 1,800 people, and we would find 605 cases out of the total of 808. If we were to use one of the logistic regressions, we would have to screen about 130 more people, but we would also find more lung cancer cases. However, if we use the random forest model, we would only have to screen 1,700 people, and we would also find 25 more cases than in the case of the pure smoking and over 50. And if we use the decision tree, again, we'd get similar results to the random forest. We can't compare this with other statistical risk models because we don't have the same variables in our data sets, but this is very encouraging. And then we wanted to also look to do a further feature selection and see which are the most important features in our geospatial dataset. We used 3 types of feature selection options, and these are the results for the Boruta feature selection, which says that the concentration of particulate matter is more important in the Chuland, in the Belgian and Andalusian dataset. The heavy metal concentrations are important in all the datasets, and so is the deprivation index, so the socioeconomic deprivation. The agricultural land cover in the Belgian and the Basque Country dataset, and elevation in the Basque Country, so in the 2 Spanish datasets. We also looked at feature importance to see which of the features contribute more to the model predictions, and as expected, we could see that smoking is in fact the most informative feature, but we could also see here what we couldn't see in the feature selection, that the radon exposure, so here the radon class 0 means that the person is living in an area where 90% of the houses are it's basically the safest zone. So the radon exposure is one of the most informative features as well. This is a feature importance using Shapley values. And then we also did a permutation feature importance for the Belgian dataset, which again showed that radon is an important radon exposure class is an important predictor for lung cancer risk. And that was basically the conclusions that we could draw. And then we shared these conclusions with our partners who are performing genomic analysis to look at the possible pathways for these geospatial exposures, for these environmental exposures. So for the geospatial analysis part using machine learning outputs, what we wanted to do was to look if there is any spatial clustering for the model errors. So if the false positives in our predictions are clustered in any particular area, and if the false negatives are also clustered. We couldn't actually see very much from this. We could definitely see some high clusters, but our further analysis revealed nothing that we could use further. And we also did aspatial clustering. So we performed a nearest neighbor cluster, and we wanted to see if these aspatial clusters have any spatial patterns to them. And you can kind of see it, but nothing popped out or was significant in our analysis, so we decided not to pursue this further. However, when we did the last step that I'm going to talk about, the machine learning using geospatial analysis outputs, we could actually see, firstly, that the level of the administrative unit is very important in the hotspot analysis. So we performed local Anselin Moran first. These are the results for the Basque Country, and we did it at several administrative levels. So we did it for the census tract, for the postcode, and for the municipality. And you can see that in both the census tract and the postcode analysis, the high in dark red here are census or postcodes are among this is the Basque Country and this is Bilbao, so they are among the most urbanized areas, and also the lows are basically the suburbs of those urbanized areas in Bilbao. However, for the municipality, you could only see this high cluster in the northeast of the Basque Country, also accompanied by some high-low clusters here. However, if we added the hotspots analysis as machine learning features, so we could actually see a consistent, although small, improvement in the model discrimination ability. And we also looked at what differentiates the high and the low census tracts. And we could see that, in fact, the concentration of particulate matter was not significantly different between the two type of clusters, but that of nitrogen oxides was. Similarly, we could see that the urban land coverage, the population densities were not different between the two, but we could also see that both the agricultural land coverage and the green space access was. So what we wanted to do was to retrain the models, but then use the degree of urbanization as a segregation variable. So we trained the models and tested them on the urban patients, the peri-urban patients, and the rural patients, and we could actually see an improvement in our models. We could see they are performing better for the urban and rural patients and slightly less for the peri-urban. But overall, if we combined the results of these models, the overall models perform better than the block models. So I will end by just pointing out some limitations of our study. And that is, they are mostly regarded to the data availability across different regions and countries for air pollution, soil pollution, and also the census information between Belgium and Spain is quite different, and they are as are the methodologies for radon risk and radon exposure, and the reporting data are quite the availability of data is different. Such also that stands for the calculation of the socioeconomic deprivation index, and furthermore, there is a big difference between the population distribution and the size of administrative units between Belgium and Spain, and that can skew our analysis. There's also the uncertainty regarding pollution exposure, because we're considering the exposure basically as an average, yearly average, annual average of the census tract or municipality that person has their residential address in, but they may be exposed through other to different levels through their jobs, and we do not have that information. And finally, this is a low number problem both for the machine learning and the geospatial analysis, because thankfully lung cancer cases are not that frequent. And that would be all from my side. Thank you very much for your attention. Thank you very much for having me for this. And if you have any questions, I will be happy to answer them.
Thank you very much. That was fascinating. Does anyone have any questions? I have a question to start. Why did you choose those regions? Was it just availability of data?
It was that data availability, because that was our consortium. It was made from, yes, that was the people who were inside the Horizon 2020 project. So it was what data they have. I forgot to mention this, but also the data is at different levels. So we have the data in Belgium comes from a hospital, while the data in Spain comes from the national health authorities. So it is much more complex, and it has more levels. But it is the provenance is because of the partners and what they had available, and yeah.
And are there any plans to expand it to other regions?
So I would very much like to expand it to Ireland. But we would have to get some sort of yeah, we'd have to get a project to get this together and to have access to, I think cancer registries would be better than just cohorts for this type of analysis. So we'd have to get access to that, which is slightly problematic in both Ireland and Northern Ireland, I imagine.
Yeah, yes.
Yeah.
We have a question here. Was there any data used to reflect mitigating measures for radon exposure, such as the use of radon barrier sheeting in subfloor construction of buildings? And thank you for the brilliant presentation. That's from Dara.
Oh, no, there was no data about this, and we couldn't, sadly, we couldn't do that, because that kind of data I don't think is available at the national level. And because for some of the patients, we only had the postcodes or the census tract and not the street address, we couldn't actually take that into account. We also know that it's important what level of the dwelling you're at, because the higher up you go, I think the less radon exposure. So that would be really interesting to take into account. But unfortunately, we didn't have the data availability to do that.
I see. Yep. I have a question here from Ronan O'Keefe. Fascinating presentation. What software packages did you use to do the analysis?
So we use so for the geospatial variables and their transformation and everything, my colleague Aileen used ArcGIS. I did a little bit of that using Python and the GeoPandas package in Python, and all the machine learning and the geospatial analysis, so all the hotspot analysis was done in Python using the scikit-learn package for machine learning, and ESTA, I think it's called, exploratory spatial data analysis package in Python.
Okay, brilliant. Thank you. I have another question from Sita. Insightful presentation. I was curious if false negative rate low should be used as an indicator of good model as opposed to good detection rate. As in health section, it's more critical not to miss the real case than the low side effects from including false cases.
Yes. So that's a very good question. And I'm afraid I cannot answer that. I think that is more of a question for the people who will actually use the models, because I think that's more of health economics, maybe a question, and you'd have to yeah, I think it's a very difficult question on how to basically prioritize the false negatives versus the false positives. And if you're screening more people who are healthy, but who might turn out to have through the current screening, which is the low dose computer tomography, there's a lot of false positives with that as well. So there's a balance between getting to more cancer patients, but also unnecessarily screening a lot of people and then doing all that, who are probably thinking, oh my God, what does this mean? And all of that. So it's a very good question, and I think the best way would be just to increase the accuracy of the screening. But I don't know the answer. Basically, it's above my pay grade, I would say. It's
And I don't think we've other questions, but I've one more from myself. Did you find that doing the analysis without having, I guess, a medical background was okay because you were focused more on the geospatial side, or do you think having a medical insight would have been beneficial?
having a medical insight would definitely have been beneficial, more beneficial. For example, we also included some clinical variables, and it would have been good to know that COPD, so chronic obstructive pulmonary disease, can actually be diagnosed after the patients have a lung cancer diagnosis, although it has been developing all this time. So in the first stages, we didn't consider the people who had COPD diagnosed after the lung cancer diagnosis, but they told us no, actually they probably have it beforehand. And so we do have a lot of clinical partners, and we are trying to get their insight into what our analysis is telling them. But mostly we're working with genomics people to use the outputs of our analysis into their models.
And
But
is this an ongoing project, or is there a finite time limit on it?
So it started in 2023. It's going to end at the end of this year in 2026. And we hope to be able to use the models we've trained for the prospective data set for the retrospective data set for the prospective data set. So for the people who are currently being screened, we'd like to see if our models actually make a difference or not, if they would have different results, basically in assigning them a high risk or a low risk status.
Okay, sounds great. We have another question coming through.
Oh.
It's from Anastasia. Did you use any data balancing techniques during the model training?
So we used, I would say, all of them. Because the data was so imbalanced, we used so we used weights balancing, which is just adding a penalty to the uh, wrong predictions that are uh, um, proportional to the weights of the data, the lung cancer in the control cases. But we've also used SMOTE. We've also used so we've used both oversampling, which is basically you add more synthetic samples. We've used undersampling, which is reducing the proportion of people without lung cancer in the data set, and we used the combination of oversampling and undersampling as well. So we've used all of that was available in scikit-learn, and basically the one thing that worked was using the weights balancing. Otherwise, it actually performed poorly, more badly than without.
Without doing it. Brilliant. Yeah, thank you. I'll just see if there's any more questions. But yeah, it was fascinating. A lot of technical detail.
I'm I'm sorry.
No, it was brilliant.
Yeah.
Absolutely brilliant to see the nitty-gritty of all that went into it. And that's it. We might finish up there if we don't have any more questions. I just want to thank everyone for joining us. A huge thank you to you, Valentina. And of course, thank you to all our attendees for being part of today's session. We appreciate your engagement, your questions, and your continued support of our webinar series. Quick reminder, the recording of today's webinar will be available on our YouTube channel, so feel free to re-watch it or share it with colleagues who couldn't make it. We're also excited to announce that our next webinar will be held on the first Wednesday in April. Thank you and enjoy your day.